Good morning, everyone. Thank you for joining us again for another talk during the Summer 21 Health and Wellness Lecture Series brought to you by Kusudi International Incorporated. Today, I am super honored and elated to introduce my friend and sister, Dr. Queen Banuzzi. She is the CEO and owner of and a podiatric surgeon at the STEP Podiatry Center in Bowie, Maryland. She also serves as chief of podiatry at Doctors Community Hospital and is a consultant at their Center for Wound Healing. Dr. Banuzzi attended Vanderbilt University for her undergraduate studies with a BS in math and also attended Rosalind Franklin University for her doctorate studies. Unlike most physicians, immediately after completing surgical residency at Inova Fairfax Hospital, she opened her private practice in 2011. She stresses the importance of educating parents, patients, and preventative management of conditions of the foot and ankle. More importantly, she is a beautiful soul, and I am so honored that she is going to bless this series for us and educate us today on the diabetic foot. Thank you, Dr. Manuzzi. Thank you for your expertise, and we look forward to hearing from you.
Awesome. Welcome. Thank you so much, Nia, for that introduction. I truly appreciate that. This is a subject that I'm very, very passionate about, so I am very happy to give this talk. So often, one of the things I hear patients and people ask me is, hey, can you look at my feet and tell me if I got diabetes? Unfortunately, I don't have the magic ability to see diabetes in a feet. However, I will discuss some of the things that I look at when I'm evaluating the foot, especially if they're diabetic. You may see some things in this lecture that may turn your stomach. So this is a disclaimer, if you're eating breakfast right now, don't say I didn't warn you. This is my real life every day. This is what I see with the diabetic foot. And so my goal is to really prevent some of those complications that I see associated with diabetes in the feet. Next slide. So what is diabetes? I see a very high diabetic population. I work both in a hospital setting as well as the office setting. So I see diabetes at all stages, from people who are first newly diagnosed to people who are in the hospital, trying to save their life. Diabetes, or sugar, as some people will call it, is a chronic condition that causes a buildup of blood sugars in the bloodstream. So typically what happens is whenever we eat food, especially your carbs, it's broken down into sugars. These sugars are then entered into the cell so that we can use it for energy and to restore the body and have things function. There's a hormone called insulin. Insulin is the hormone that breaks down that sugar so that it can enter the cell. Unfortunately, sometimes the insulin is not working properly. We don't have enough. We don't make any, period, and this causes the sugar to build up in the bloodstream. The problem with that is it creates an immunocompromised patient. It also will damage the tissues as well as the organs in the body, and that's why it's considered a very chronic condition. There are several types. Type 1 is more of the autoimmune. It's typically when the cells in the pancreas are attacked and it causes patients to no longer create insulin. You typically see this in your younger population, and it's about 5 to 10% of the diabetic population are going to be your type 1. Type 2, this picture here is my type 2 diabetic here. This is largely preventable. I say largely because there is some genetic components to it, but that and in combination with the environmental factors, meaning lifestyle, diet, physical activity, these are the things that contribute to type 2 diabetics. And this is 90 to 95% of all diabetics. There are also gestational diabetes that patients can get when they are pregnant that typically will go away when they have the baby. Pre-diabetes or borderline diabetes, those, 1 in 3 Americans are pre-diabetic, which is a lot. Pre-diabetes, what I tell patients is it means your blood sugars are too high, but not high enough to put on medication. So very important that the moment your doctor tells you you are pre-diabetic, that you get your act together, get your diet together, start working out, because you're just a step away from becoming type 1 or type 2. Next slide. So prevalence of diabetes, these stats are from 2018. So right now, over 10% of the nation are diabetic. The higher incidence are in patients who are people who are over 65. There's also a higher incidence in minority population, highest being in the Hispanic population, then the Blacks, and then Asians, and typically that's more of your Asian Pacific. 1 in 5 million new cases of diabetes are diagnosed every year. Diabetes is the 7th leading cause of death in the United States. I put the asterisk there because COVID is here and I'm not sure where it fits in that line. But back in 2018, diabetes was the 7th leading cause of death. As a podiatrist, one of the biggest things I see are your ulcers and amputations. 15% of diabetics will experience a foot ulcer, which is a sore in the foot, which typically precedes an amputation 85% of the time. And lastly, diabetes is the leading cause of below the knee amputations. Next slide. Complications, so several complications associated with diabetes. Like I said, the high blood sugars cause damage to your organs and tissues. Blindness is very common in your diabetic population. It's also the leading cause of end-stage renal disease, meaning putting patients on hemodialysis. Heart disease and stroke. Diabetics are 2 to 4 times higher risk of a heart attack or stroke. Often your diabetic patients will have something called a silent heart attack. And they don't have as high symptoms when they have these silent heart attacks, but it makes them more prone to a more fatal heart attack later. When the heart is damaged by the diabetes, that means all the vessels that branch out from the heart are also damaged. And this is what causes the poor circulation that we see in the feet. Lastly, neuropathy, meaning nerve damage. A lot of times, like I said, 60 to 70% of diabetics will have some sort of nerve damage, which causes them to not feel pain the way we feel pain. And if you can't feel pain, you can't respond to fix it. Next slide. Amputations. Unfortunately, I do a lot of amputations. A majority of the foot emergencies that I see in a hospital setting are going to be your diabetic infections that require amputation. One of the biggest fears most of my patients have about going to the hospital is the risk of amputation. However, my advice to them is you go in the sooner you can, because the sooner you come in, the more options I have for you. You come in too late, I have no options. As a foot doctor, my goal is to save feet. Every time I amputate something, that's taking business away from me. So there's it's not in my best interest at all to amputate. However, at times it is the only thing to do in order to save the limb or save the life. On this slide, as you can see, below the knee amputations come with a lot of risk later. 42% of people who lose one limb will lose the next limb the next year, and 68% of them will lose the other limb within 5 years. 50% of them have a 3-year mortality rate. That's because whenever you lose a limb, there's a higher heart energy expenditure when you just have one limb. And so you're more likely to die, once you lose a limb. So really important to do everything to prevent that. Lastly, annual costs for amputations typically go to $30,000 to $100,000 per amputation. So it's a costly business, definitely. Next slide. Early diagnosis and appropriate management of the diabetic foot are extremely important because the consequences can be so severe. This is why you need to have a relationship with your foot doctor. Small things become big things so quickly with the diabetic population. I really stress having a good relationship with your foot doctor. That way, the moment you see something, you know where to go, how to treat it in terms of what, the relationship you have with your foot doctor. If you don't have a foot doctor, typically those patients will start to try and self-treat and make things worse. Next slide. These are the goals as a podiatric physician: early identification of the high-risk foot, early diagnosis of foot problems, early intervention to prevent amputation, and most importantly, educating my patients on proper care of their foot as well as what they wear on their foot. Next slide. So what does not happen in the podiatry office? There's not much massaging. I'm not doing much pampering of the feet. We do routine care for diabetic patient. That means just trimming calluses and cutting nails. One of the reasons why is so that we can evaluate things that the patient may not see, so we can prevent any kind of future problems. Next slide. Podiatric evaluation is comprehensive. Some of the symptoms of diabetes are you urinate a lot, very thirsty, losing weight, but you're not even trying, very hungry, some blurry vision, tingling of the feet, dry skin, sores that aren't healing. Or so these are some of the symptoms that come with diabetes. Typically, when you're seeing these type of things, your primary care or even I sometimes will go ahead and order some lab work. We'll check your circulation, we check your nerves, check for any deformities in the foot. We look through x-rays, check your skin, evaluate the shoes, as well as any prosthesis or braces you may be using. And like I said, educate. Next slide. So the lab evaluation. So back in the day, in terms of diagnosing diabetes, they used to make you do an oral glucose test where you do your fasting glucose, and then they would make you drink a glucose drink, just a real sugary drink. And then test your blood sugars afterwards. And if it wasn't less than 140, then you were diagnosed with diabetes. Now we can pretty much check your blood sugars and tell you whether you have diabetes or not. Your fasting blood sugar, if it's equal or greater than 126, then that's diabetes. Your random blood sugar, if at any point someone check your blood sugar and you're over 200 or above, then that's diabetes. Hemoglobin A1C is a very important indicator of diabetes. It gives us your average over 3 months of what your blood sugars are. So typically my patients, I'll ask them what their blood sugars are. They say, oh yeah, doc, it's very well controlled. It's usually 100, it's usually 100, it's usually 100. And then I'll check their hemoglobin A1C and find out it's 9, which is not an average of 100. Any hemoglobin A1C of 6.5 or greater is considered diabetes. That means you're averaging of about 150 in your blood sugars. Your BUN and creatinine, this is how we evaluate kidney function, and this is very closely associated with diabetes. White blood cell and SID rate, this is how we evaluate inflammation, typically associated with infections. Albumin and pre-albumin is a way to evaluate your nutrition, especially with wound healing. We want to make sure that you have adequate protein. Next slide. Vascular exam, this is very important with diabetes because poor circulation is often associated with the amputations. We will typically do just manual check to check your pulses on the foot. ABIs and TBIs are screening evaluations that should be done at least yearly, or at least see your vascular doctor once a year to get something more objective. In terms of what your circulation is doing. PPGs is where they kind of check the blood volume within the toes to see how the smaller vessels are doing. Doppler exam, if we do see something in the screening that we're concerned about, we do a Doppler exam, which is just an ultrasound to really be able to see those blockages. If there are bad blockages, then your vascular doctor will order MRAs or angiogram where they actually can see the blockage by injecting contrast into the vessels and seeing if they can open things up. Next slide. As I mentioned with the vascular exam, ABIs, they're not as reliable for diabetic patients due to calcifications. What we typically do is we take pressures in your arm and pressures in your legs, and then we compare them, and the ratio should be about 1 or 1.2. If it's higher than that, typically that's calcifications. The lower they are, the more risk of non-healing and severe disease that you have. And so these, like I said, are screening tools that will refer you for an ultrasound or to a vascular doctor for more intervention. Next slide. One of the biggest reasons why we do the vascular exam to check for poor circulation, also known as peripheral arterial disease. Risk factors of peripheral artery disease, of course, one is diabetes. A big one is smoking. It's, my diabetic patients, smoking creates a fatty buildup in the vessels, which makes the arteries smaller. It also allows carbon monoxide in the bloodstream which reduces the amount of oxygen. So all these are things that will affect healing long term. If you do quit, 1 year after quitting smoking, you're able to decrease the risk of heart disease by 1/2. And after 5 years, the vessels start to widen back up. So you can always quit and help yourself. You're not doomed. Next slide. ischemia, which means lack of blood flow. These are all kind of signs and symptoms of poor circulation. Claudication is when muscles start to fatigue whenever you're walking because of poor blood flow, and you get relief whenever you actually stop. So typically people will walk a block and they can't walk anymore because it hurts, and then they rest and they get some relief. Pain in the foot, especially at rest, like when you're just not doing anything. I notice this a lot for patients at nighttime when their feet are up. Not able to feel the pulses, if the skin is really shiny or thin. If there's no hair on the foot, that means you're not getting a lot of blood flow to support hair growth. Dependent rhubarb, that means when you put your feet down, they start to turn red because the capillaries are not able to constrict anymore. Painful or non-healing wounds, wounds that don't heal. When you don't have good circulation, you're not able to create new blood flow, new blood vessels in order to help the wound to heal. And then lastly, as you see in this picture, this is gangrene. So some people are like, ooh, do I have gangrene? No, this here is what gangrene is. Gangrene is complete lack of blood flow to an area that causes complete death of the tissue. It's black, it will not come back. It will not ever come back, it is dead. So that's what gangrene is. Next slide. So our neurological exam, pain is the gift that no one wants. And so like I mentioned, a lot of diabetics with the blood sugars clogging the nerves, they don't work appropriately, and the patients don't feel pain the way we would feel pain. When you don't feel pain, you can't compensate for that pain. You can't treat that pain. And so that becomes one of the reasons why some of treatment is delayed with diabetic patients. Next slide. In this picture, you see what we call a monofilament. This tests our protective sensation. You'll be surprised how many times I've seen patients come in the office, a nail in their foot, a pin in their foot, and they have no clue because they just didn't see it, but they don't feel it. Vibratory and proprioception are typically the first things that you lose whenever the nerves start to be affected. And so that causes a lot of balance issues. Some of the symptoms patients will have is numbness, tingling, shooting pains, especially at night when the nerves are most active. Next slide. So this is why we do routine care for our diabetic patients. They come in just to cut their nails or calluses, this patient, I cut his toenail and told him, you got a hole at the tip of your toe, and had no clue because just didn't have any pain. Next slide. Because of the poor nerve sensation, one of the biggest things we tell patients to do is to avoid a heating pad, avoid hot water, avoid soaking in hot water. Make sure you test it out with your hand or have someone else test it out for you, and do not walk barefoot. People will walk barefoot in their homes and you'll be surprised what kind of things you pick up. Next slide. So this is over the years, some of the things I've pulled out of people's feet that they had no clue they had. This is a sewing needle in someone's foot. I remember her, she had no clue why her foot was swollen, and that was that. This patient down below, that's a toothpick I pulled out. Pulling out foreign bodies is literally a needle in a haystack. Like, it looks great, it looks easy enough when you see it there, but when you open someone up, you have no clue where it is in terms of those the 3D dimensional plane. So it's never fun trying to find some foreign body in someone's foot. Next slide. These are patients, these are some of the burns I've seen over the years from my diabetic patients. A lot of times it's the heating pad, the soaking in the hot water, because they just want their feet to feel good because they feel the neuropathy, they feel that tingling sensation, but don't feel the pain that comes with that. Next slide. Orthopedic exam, the biggest thing I'm looking for are just different shapes, deformities, the range of motion in the foot, so we can make sure we get the right shoes and inserts to accommodate that. Just because something's deformed does not mean I need to operate on it. The biggest thing is just accommodating it so it doesn't cause problems later on. Next slide. We'll evaluate patients standing as well as sitting, just to make sure they're in the right shoes. A lot of times, a lot of these patients will have really flat feet. Next slide. Shear forces are things you're looking at. Patients who wear shoes that are too big will end up getting a lot of friction and blisters, static deformities. These are some of your hammer toes, claw toes. These are all contractures that really can change the pressure points in the foot that can cause breakdowns and ulcers in the foot. Next slide. Like I said, hammer toe deformities are really big in your diabetic patients. A lot of that is also with the neuropathy. Not only do they not feel things as well, it affects the motor, it affects the muscles, and so can cause some imbalance of the muscles, and which can create contractures. So biggest thing is making sure they're wearing appropriate shoes to accommodate the deformity so they're not getting a lot of rubbing. Next slide. So this next patient is a patient with a hammer toe. Because of that bend in the toe, he was getting a lot of pressure at the tip of the toe, and you can see he has a wound. Next slide. So we were able to, he had some bones showing at the tip of that toe, and so we ended up having to amputate it because it was infected. Next slide. We closed that up and he was able to heal very well. Next slide. This is another patient. Next slide. With a hammer toe deformity at the top of that toe, which went down to bone because it was rubbing in the shoe and just didn't feel the pain from it. We ended up having to remove some of that bone once again because it was infected. And we're able to sew that up. And these are some of the residual deformities that come with us trying to balance saving a toe and just kind of, piecing together what we can so that we can remove the infected tissue. Next slide. Bunion deformities. Bunion deformities are typically elective, meaning it is not necessary unless it hurts and there's a functional disability. With my diabetic patients, I rarely do something elective unless it is necessary. It's very important before I do anything elective that they have very good blood sugar control, because if you don't have that, then and you don't heal, then you have something worse than a bunion is an amputation. Next slide. And so this patient, bunion deformity, like I said, biggest thing is, accommodating it appropriately in shoes. And if we can't, then we can consider surgery, but very important that they have good blood sugar control so they can heal the surgeries that come with that. Next slide. This is a patient with a kind of crossover deformity as well as a bunion. Very difficult to find shoes that prevents rubbing. And so this patient did get operated on. Next slide. Next slide. Charcot. Charcot is a very complex deformity that we see in diabetics that is triggered by just a small trauma. Because diabetes affects the nerves as well as the vessels, it can cause a denervation of the arteries, which causes an inflow of blood to the foot. This blood starts to soften the bones, and because these patients don't feel pain, they're stepping on soft bones and create fractures, dislocations, and severe deformities as a result. Next slide. One of the biggest deformities we often see with this is a rocker bottom deformity where the arch collapse, and so there's a prominence at the bottom of the foot. Next slide. Because of that diabetic Charcot neuroarthropathy, like I said, they don't feel it. They get this deformity. That deformity has extra pressure breaks down into an ulcer. So they end up with this wound that is very difficult to heal because you have a residual deformity with the bones that isn't corrected. So it's very hard to heal these kind of wounds. Next slide. Some of the signs and symptoms of a Charcot arthropathy is pretty much a hot, swollen foot. Sometimes a patient will start feeling pain and you're like, oh, why are you feeling pain? You typically don't feel any pain. And that's from all the fractures in the bone. These patients typically have actually really good blood flow, and that's why they're more prone to Charcot arthropathy. Next slide. One of the problems, next slide. And next slide. One of the problems with Charcot is that it mimics, you can go back for me. It mimics other things like cellulitis as well as gout because it's just a red hot swollen foot. And so sometimes we have to get bone scans or different imaging to kind of differentiate between Charcot versus some of these other things. Next slide. The key to this is prevention, putting them in accommodative kind of insert to kind of hold up the arch. So just we prevent some of the collapse. Next slide. offloading whenever they're in acute Charcot phase where it's very hot, very red, very swollen, and the bones are breaking. One, you want to keep them off as much as possible. We have different specialized boots and casts to really kind of help offload it so we minimize the amount of fractures and dislocation and deformity that happen while the bones are soft. Next slide. When we're unable to get them into a shoe after the deformity, unable to brace them, unable to heal wounds, that's when we have to consider surgical options. This here is what we call an external fixator. It looks like a cage, but we span it across the foot to hold the foot in place while the bones are soft. Sometimes we do it just to correct the deformity. Next slide. This here is a patient who had a residual deformity at the ankle as a result of the Charcot. So eventually he ended up having surgery where we just fused the ankle. Next slide. Unfortunately, sometimes these deformities are too severe and the wounds get badly infected and they do end up with amputations. Next slide. X-rays are another evaluation that we do. We like to get baseline X-rays so we know what your foot typically looks like. So when there are changes, we have something to compare it to, able to see infections, especially bone infections, fractures. You can see calcifications in the vessels using X-rays as well as any arthritis. Next slide. There are some questions that Google cannot answer. So, a lot of times patients will see things on their foot and they want to, Google and WebMD and diagnose themselves for weeks and weeks and before they actually go see somebody. Like I said, with a diabetic patient, something really small can become something very big very quickly. So really important that they go and see their podiatrist immediately, especially when they see skin changes. Next slide. Some of the things we see in terms of the skin, fungal nails, athlete's foot, sweaty feet, blisters, tumors, small skin infections, calluses, which can lead to ulcers, which are sores in the foot. Next slide. You can see these are some of the things we see. Like I said, calluses often will lead to ulcers. Athlete's foot, I've seen some really bad infections just from something as small as athlete's foot. So really checking between their toes and really treating those aggressively. Next slide. This is actually a patient with a bad athlete's foot. Luckily, this person healed pretty well. Next slide. Bullosis diabeticorum, as well as necrobiosis lipoidica. These are some skin conditions associated with diabetes. On there, this is what we call an Unibut, which has zinc and cameline, which help to control some of the swelling, as well as help with healing some of the dermatitis associated with these conditions. Next slide. One of the reasons why we don't let diabetics go see get pedicures, because things like this can happen, those ingrown nails that they start digging for. Once again, if the patient doesn't feel the pain and they get nicked, it can lead to something big and bad. And I've had people come in with lose their toe off of going to get a pedicure and having an ingrown that got too infected and the bone got infected. So really important not to self-treat. I tell my diabetic patients, don't cut in the corner. Cut straight across. In the corner you can file, but don't cut in a corner because you just don't want to run that risk of something that doesn't heal. Next slide. These are some of the really bad fungal nails that we have to cut, and you can see what kind of problems this can cause. I don't even know how some of them wear shoes, honestly. Next slide. Ulcers. These are some of the things, like I said, I work in a wound care center, so I see ulcers of, the small ones, the big ones, the really bad ones. People with poor blood sugar control, very hard to heal the wounds. The neuropathy makes it difficult to keep them off the foot because they don't feel any pain. Vascular disease, we don't have good circulation and they don't heal. Limited mobility will put extra pressure in areas and deformities. If they've had amputations, their risk of more ulcerations just because the biomechanics have also changed. Next slide. When I'm evaluating these ulcers, I'm looking at how deep they are. I'm looking at the base of it. Is it black? Is it red? Is it healthy? Is it not? Is it draining? And does it smell? These are all things that help us determine kind of how severe this wound is going to be, whether they need if I can treat them in the office or if I need to send them to the hospital. Next slide. These are other contributing factors, their nutrition status. And like I said, we check their albumin because, making sure they're getting good protein is really important for them healing, whether they have good oxygenation, meaning like if they're smoking, it's very hard to heal a wound that's this huge on the right. So these are all things that contribute to trying to get the wounds to heal. Next slide. One of the reasons why these patients have these chronic wounds that don't heal with the diabetes, their immune system is compromised. And so if our typical wound healing model is, 21 days or so, these patients typically are stuck in this inflammation stage and never kind of move on to progress. They don't have good angiogenesis or formation of blood vessels to help with getting new growth factors to the wound to kind of help the cascade along. This patient here with these stitches, this small, tiny wound that you would think should heal with no problem, diabetic patient, poor circulation. This took him, I think, 2 years to heal. Next slide. We use a combination of several things to try and get wounds to heal. The goal is balancing the wound environment. If the wound's too dry, you want to make it moist. If it's too moist, you want to make it dry. So it's a balance of kind of doing a bunch of things in terms of ointments and pads, as well as some more advanced modalities. Next slide. Controlling infection is very key to a wound. There's no wound that's going to heal if it's infected. So just putting them on antibiotics, sometimes that's through an IV, sometimes that's just pills, sometimes it's topical. Next slide. If the infections are deep, especially with the bone, typically we're having to do some sort of imaging. This is an example of a bone scan. MRIs we often use as well, but the gold standard is actually taking a piece of the bone, sending that to the lab and seeing if it has infection in it. Next slide. So this is a patient on this x-ray, you probably won't notice it, but there's some black kind of tissue right around that bone. That is gas, we call it. So this is gas gangrene. He has infection to the bone. This is really a very, very bad infection. So we opened it up and luckily we were able to save his toe and just remove some of that bone and keep him on some IV antibiotics. Next slide. Other things we use different skin substitutes. A lot of times with diabetic patients, because they're immunocompromised, I don't like taking skin grafts from that patient because, one, I'm creating another wound, but two, if they don't have good kind of protoplasm for healing, then I don't know why I would think that skin would be good for healing. So luckily there are a lot of different skin substitutes on the market, just kind of bioengineered the living tissue, some made out of placenta, some made out of different animals like pig and cow tendon that we can use to help heal wounds. Next slide. We also use something called hyperbaric oxygen treatment, where we help kind of perfuse more oxygen into the body. These patients can lay in an oxygen chamber for about 2 hours a day for 30 days to help with these wounds. So you can see there's just a lot of extensive things we have to do to try and get wounds to heal with a diabetic patient. Next slide. We often use something called a wound vac, which is a sponge hooked up to a suction device that helps kind of fill in the wound. It also takes some of the fluid out the wound to kind of help these wounds to heal. Next slide. Next slide. This is a chronic wound that does not look that healthy. We put this wound vac on. That's that sponge hooked up to the suction device. And then next slide. And so you can see it improving. It looks much healthier. It's redder. By the next picture, one of the wounds has already healed, and now we just have the last one to heal. Next slide. This is not my patient, but this is maggot therapy. Maggot therapy is used in an inpatient setting in the hospital. It's not just maggots outside on the street. There are medical grade type maggots that we use to help with kind of cleaning up the wounds in some cases. Next slide. Offloading, keeping pressure off of the wound. That's one of the biggest things. That's one of the hardest things as a foot doctor. It's hard to tell people to stay off your foot because they got to work, they got to eat, they got to do all kinds of things. So staying off the foot is hard. So we, in this picture, this is a pad that we've used to kind of take some pressure off of it. Next slide. Plantar pressure. So this scan kind of shows where we normally put pressures on the left-hand side. You can see the normal pressures. The redder it gets, that means the more pressure we have. The middle slide, so hallux limitus is a deformity where you have arthritis in the big toe. So you can see right there in the big toe where there's more pressure at that joint. And then the next side is that Charcot that we discussed where they have that rocker bottom. So all the pressure is right there in the middle of the foot. Next slide. Oftentimes I'll have to do a lengthening of their Achilles just so I can take some of that pressure off of that, and that can reduce some of the pressure by 20–25%. Next slide. This is just kind of schematics of how we kind of lengthen an Achilles. It's almost like having a rupture, but not a complete, so they're really off their foot for a while just to prevent that rupture because it's going to be weaker until it heals. Next slide. One of the biggest reasons why patients get wounds are the shoe gear that they're wearing, making sure they're wearing appropriate shoes. As you can see, I trace this person's foot and then the shoe they put on and say, yeah, you can't wear this shoe. Next slide. Different braces and orthopedic diabetic shoes, and some of them have gotten much better, so they don't all look like that anymore. Next slide. Making sure they're wearing appropriate bracing. Next slide. And fillers for their amputations. So in terms of diabetic foot education, biggest things, make sure they look at their foot daily. And this patient's looking, sometimes you have to use a mirror if you can't bend down there. Keep your foot clean and dry, looking for blisters and cuts, avoiding heating pads or hot water, avoiding medicated pads. Medicated pads don't know the difference between good skin and bad skin, so have them avoid that because they don't feel pain. Wearing white socks so you can see when something starts to drain, checking your shoes so you don't step on a rock for a day and not know it, and avoid walking barefoot. Next slide. That's all I have. Thank you very much. If we have any questions, I'm definitely open to that.
Wow. First of all, thank you so much. That was amazing. I learned a lot. I do have a lot of questions, so I'm not going to take up all of the time. But my first question is, what brings a diabetic patient to you? Is it part of the medical model? If there's someone who's diagnosed with diabetes, do they have regular visits with you? Or is it always kind of after something happens that they come to your office?
A little bit of all of that you mentioned. A lot of times your newly diabetic patient is going to be referred from their primary care, whoever just diagnosed them. Sometimes I see them for the first time and meet them as a diabetic patient in the hospital setting. And so then I have them follow up with me routinely. And depending on, how well they're controlled, a patient who ended up with an amputation, that patient is going to see me a lot more routinely than a patient who is very well controlled, has no ulcers, has no deformities, and doesn't have any kind of neuropathy or some of the complications that we see. But even those patients I see at least once a year so that we can kind of track them and make sure nothing's changing. And when things change, then we can kind of change their schedule based on that.
I have another question. You got a lot of gratitude in the chat, Dr.
No, I can't see the chat.
See, if you want to throw a question in the chat, please feel free. I do have another question. So, I thank you because this presentation really focused on individuals with diabetes. I guess my other question would be, what are the other most common diagnoses that you see? And then I have a question about a internal fixation, when someone has a fracture, and I have some questions about that.
Got it. So as a podiatrist, I see kind of all walks of life. I see the athletes, so I see some of those fractures and just some of the tendinitis, inflammatory kind of conditions. Plantar fasciitis is big. I see the foot deformities. People say, I don't like my bunion, I don't like my hammer toe, and different from a diabetic patient who I'm worried about whether they'll heal. This person will heal. They just want to be able to get back in their shoes and function the way they need to. So I see those type of patients as well. I see pediatric patients. I see your warts, ingrown toenails, fungal nails. So some of the things we talked about with diabetics, I see that in your normal population. It's just treated a little differently and maybe a little more aggressively because we're talking about an at-risk population versus someone who can heal things pretty regularly. And then in terms of, what was the question about the internal fixation?
I'll ask it after we have a question in the chat. So we have a question. First one is it good practice to not walk around barefoot for everyone as opposed to only diabetic patients?
I say it's good practice because just supporting the arch. So when you're flat-footed or when you're walking barefoot, you're giving zero support to the arch. And so one of the things in the more normal population, I'll say a regular population, is that arch collapse. A lot of times people now in homes are having a lot more hardwood floors. And so they're having a lot of ailments just because they're not giving enough support in the house. And especially now that it's COVID and everybody's working from home, nobody's wearing shoes. And so, now people are coming in all the time, my feet hurt and I'm not really doing anything. Yeah, you're still walking around the house all day with nothing support, versus when you were going to work, you wore shoes every day and you supported your arch. And so that's something I think it would be good practice, to wear something supportive in the home as well.
And we have another question, and this one is, how can an athlete or runner lessen the impact to their toes? That's a great question.
Lessen the impact to your toes. One, making sure you're wearing a shoe with a toe box that's wide enough. A lot of times I see this kind of runner's toe, and that clues me in to tell me that you're wearing a shoe that might be a little too tight on the toe. Runner's toe typically is where you get a lot of a trauma on the toenail as a result of the shoes being too tight. Two, the other thing is inserts in your shoes. One of the biggest things I do for my athletes is getting them into something accommodative in their shoe so we can take some of the plantar pressures off.
Great. Thank you so much. I have another question for you. Are there other medical diagnoses besides diabetes that impact circulation in the foot and that we should be aware of?
Absolutely. Like I mentioned, some of the risk factors, smoking can cause poor circulation, high blood pressure, high cholesterol. Those are some. Old age. There are genetic components. Also, people have something called Raynaud's that can also have, poor circulation. So definitely not just diabetes.
And my question was about when someone has an internal fixation, plates and screws. The question I used to get when I was in the orthopedic PT world was, are they going to always have that stiffness as they age and early arthritis? Do you have any information or things you can help shed some light?
So it depends on where that internal fixation is. So a lot of times, if it's closer to the joint, some of it is, some of it may be arthritis depending on where that fracture was. But over time, typically, if it's away from the joint, it will improve some of that stiffness, especially surgical stiffness is a lot of the soft tissues. A lot of the soft tissues, once you cut that soft tissue, it will never be the same. It will never be the native soft tissue that you had before. And that's why, physical therapy, I typically will send a lot of patients physical therapy pretty soon to help really manipulate that and try and get it better. But I always tell people after about a year, that's probably where you're going to be as your baseline.
And another question in the chat for the non-diabetic.
Moving on this chat, let's go.
Yeah. For the non-diabetic, what is the best practice? Like, should it be once a year, like an annual physical in terms of seeing you or a podiatrist, or does it change as you age?
So podiatry, as a specialty, I'm one of those specialties that you don't have to see regularly, like unless you are having foot problems. So it's not like your GP, your primary care that you need to see regularly to kind of test everything. There are plenty of people who come in and be like, you know what, I just want to get an assessment of my foot. It doesn't hurt. It's, I'm not having any problems. And, I can definitely tell you, okay, these are, some of the deformities I see. But like I said, I don't fix every deformity just because it's deformed. If it doesn't hurt, then what am I fixing? I can't make you better than pain-free.
Excellent. Thank you so much. If we have no more questions, please get a chat.
I had a quick question.
Yeah, go ahead. Thank you.
This is Erica. Thank you so much for this talk. It was wonderful. As you guys may remember, I have my father that just had an amputation because of diabetic ulcer. And one of the big things that I remember about the whole process is it's not short. Like, when you kind of think about it, you think like, oh, I saw a sore, this is what's going to happen. But like, it's such a long process because you want to do everything up front that's non-surgical before that last, we got to take the toe or, you know, whatever. And, he struggled with this for about 1.5 years. Medications, getting IV antibiotics to treat, infections, working, then not working. One of the things that I remember that was the most important for him after having to get the amputation and not healing was staying off of the foot. And I think we talked about this a lot. The question that I have for that is how much do you think could be prevented just by having better strategies of staying off of the foot for patients who really rely on moving around? Could you prevent that by 30%, 40%? Like, what would you say in your expert opinion about that? And the other thing is too, what advice would you give family members who are the caregivers for these patients to really, what are the best strategies to help, prevent even getting to that point?
So I'll answer the last question first. I give my hats off to the caregivers because it is a lot. It is a lot to be able to try and help a patient who you want to stay off the foot, and especially if they're an active patient that is used to doing things on their own. It is very difficult to have an active patient and tell them, no, you can't be on your foot. And this may be up to 6 months to 1 year and your wound still may not heal. On the flip side of that, offloading is biggest key to a lot of these wounds. Sometimes the wounds are at the top of the foot and I'm excited when they're at the top of the foot because I don't have to worry about them, staying on their foot the whole time and that being a problem of offloading. I've had little old ladies who I think don't walk at all at home, that can't heal something on the bottom, and I put a cast on them and in a week, 2 weeks, 3 weeks, all of a sudden it's healed. So it makes a huge difference in terms of being able to offload them appropriately. And so until patients really don't get it, but I can't give you kind of percentage, but definitely, patients who actually are able to stay off of it see significant improvement in terms of their healing when they're off of it, as long as other things are, taken care of in terms of their circulation, the infection and that kind of thing. But the offloading is one of the hardest things to do, but it's one of the most important things to do in terms of getting these wounds to heal.
All right, thank you. Thank you.
We have one more hand raised, Ms. Toomer.
Good morning, and thank you so much, Dr. Nia Menza, Dr. Queen, my sweetie pies, all my babies. Oh my gosh, I'm so sorry. I just jumped in. I just came off a worship service this morning, and a couple of things. First, a compliment to Dr. Queen. She has helped me in the area of fungus. I don't know if you covered that earlier, but my first question is, what can we do to assist us in pre-diabetes diagnoses? And also, because I'm in a warm climate, you know that, we travel in a warm climate. What can we do to prevent fungus in our toenails? And then, of course, to ensure that we prevent diabetes diagnoses as far as it relates to our feet. Thank you so much.
Got it. So in terms of the pre-diabetes, like I said, that means you're, a short skip away from going into the diabetes realm. So the number one thing is change your diet, avoid the carbs, really get into your vegetables. The more vegetables and even fruit you have to be careful of, because even though fruit are healthy, they are high in sugar. So really avoiding sugars, avoiding the fried foods. That's the key. The diet, increasing your activity in terms of, I tell people try and walk 20, 30 minutes a day, every day, just to really kind of work, because those are things that will break down the sugars more readily and prevent you from going into that realm of diabetes. Fungus, especially in your warm environments, especially if you have sweaty feet. One of the things I tell people with sweaty feet is, one, take some spray deodorant, the old school one that you don't see that often, and actually spray your feet. Just the same way it helps sweating in your armpit, it will help sweating with your feet. That's one. Two, spray your shoes with antifungal spray, just over-the-counter stuff every day. When you come home from work, you take them out, you spray them. You kind of kill all the germs that kind of accumulate just from sweating, so that minimizes that contamination on a regular basis. Your tennis shoes, things that you work out in, take the insoles out and actually wash them and make that a regular thing every 2 or 3 months. And if you're washing those and spraying them down regularly, then you're kind of decreasing the kind of fungal load that happens every day, because fungus is everywhere. It happens to everyone. However, more people are contaminated depending on the amount of fungus that you have. And if you're immunocompromised, especially with a diabetic patient, you're less likely to be able to fight some of the infections that happen with that.
Thank you so much, Dr. Banuzzi. Thank you all for joining us today. Dr. Banuzzi, this was amazing. I encourage all of you to share the information and to save it for any family members or friends, church members that may be interested in learning more about their foot health, or may have a family member that has diabetes. Dr. Banuzzi, you are my friend, my sister. I love you. I thank you. Next week, we have another amazing dynamic talk, hopefully right after church at 11 a.m. Eastern Standard Time. Miss Davion Harris is going to be sharing on ensuring diversity, equity, and inclusion in corporate spaces. She is the new head of DI at SNH. So I look forward to seeing you all next week, next Sunday. Again, thank you all and have a great rest of your day.
All right,
Thank you, Dr. Manuzzi.
Thank you. Have a good one.